will get started. So I'm Allison Link. I work for Healthy Lamoille Valley, which is our local coalition here that serves the Lamoille County and Greater Hardwick area. Our mission is Healthy Lamoille Valley is a coalition of individuals and community organizations working collaboratively to reduce youth substance misuse and engage youth to make substance-free healthy choices. We are a program of the Lamoille Family Center. So we really work on increasing protective factors and reducing risk factors. Just a little bit about the task force thus far. We had a task force years ago, and some of you were part of that. And then we lost the tobacco funding, had a hiatus for 10 years. And then the past 5 years, we gained the tobacco funding from VDH. And so we've been bringing together stakeholders approximately every 6 to 8 weeks. It's changed over time, but to inform our local logic models and to help create local collaborative strategies towards tobacco and vape prevention and cessation. In between meetings, we actually have a base camp communication group. So if you're interested in joining that, where we share information, please let me know. Just a little bit about what we've done. Last year, we collaborated to create a Lamoille Valley Quit website, which then we have promoted on posters and even little business cards, which we've gotten out around in our area. Here is the link so you can check that out. We've supported campaigns for Green Up Day and on the environmental impacts of substance use, including a survey to help map the evidence of substance use in our communities. Last meeting was really great. We met at Green Mountain Tech, and there were more students than there were adults, and there were at least this many adults. So that was very exciting, really focusing on our logic model and focusing on vaping cessation and pieces of strategies to move forward. And how we get to today's topic has been over some time having the past few years, some real conversations with our team from the North Central Vermont Recovery Center. And over the years that included Daniel Franklin and now Shannon and Ken and others, and really thinking about the topic. Yeah, just shout out, wait. So, further developing this as, focus on adults and cessation, especially in our rural area, specifically with a focus on people who use tobacco with co-occurrence of opioid use disorder, but also how the theme and the data that's presented can help support all of our work of cessation locally. So I see lots of folks who are from different agencies locally who will help with that piece of the local conversation. And I recently, I think it was the end of November, was so lucky, I feel like, to be part of a Cora seminar where Dr. Klemperer, who prefers Eli for today, well, welcome. We're so glad that you could join us again for and share with us some of your information. Welcome, Matt. Glad you can join us too. And so with the synergy really of the conversations that we've been having with Shannon and Ken at the Recovery Center, as well as being part of some of the statewide and then also some national work on this topic, it was appropriate and so wonderful to be able to bring it together for this Tobacco Task Force meeting. So I would like to just share just the overview for today's agenda, and then we'll get right to it. Dr. Klemperer will offer presentation. We'll do a quick reflection, and then we'll really bring it local. And so that piece, Val Valcor, who's Val, can wait, I don't know, she, our local Morrisville District Office Health Department chronic disease designee and just wonderful colleague in the work, now back from COVID duty, really active in collaboration. Thank you, Val, for being here and all your collaboration. So we'll bring it local. I know Shannon Chauvin and also lots of other folks who are here. I see Dana and I see Matt and so many people who work in our community, and John, everybody who will be able to share local conditions. The Craftsbury folks, great that you're here too. And we will move towards how do we make an impact in this area, do some brainstorming, and then think about where from here. So that's the pretty much the overview. Any questions so far? I do want to mention that the Green Mountain Access TV is recording the sections through the presentation pieces, and then we'll stop recording. And we thank them for all their support always. Really terrific partners and collaborators. So thanks again, Maya and Tim, for being here, and Amy for all the work as well. And so I'd like to present to you all, and thank you again so much for coming, Dr. Klemperer, who's the assistant professor at the University of Vermont in the departments of psychiatry and psychological science, and an investigator with the Vermont Center on Behavioral Health. So I'll hand it over to you. I want this to be very active, so let's get that chat going, and any questions that you have really up in the chat. And we'll be able to address them. And I'll do my best as a facilitator here, keeping in mind that if you all need to jump in or to help me make a correction or a better way of saying something, please let me know how to keep that equity lens also in mind. Thanks. All right, Eli.
Thanks, Allie. Yeah, appreciate the introduction. Let me start by just trying to share my screen here. So can you all see my slide without my notes? Great. All right. So yeah, as Allie mentioned, I'm an assistant professor at the University of Vermont, and I'm really grateful for the opportunity to come talk today. Allie was telling me a little bit about all the important work that is happening, and it's exciting to hear about. I'm looking forward to learning more about it in the second half of the call. So I'll focus on some research on applying motivation phase interventions to treat tobacco use among people with opioid use disorder, really looking at that specifically through a rural lens, given how important that is to our state. And throughout the presentation, I'll really try to focus as much as possible on the research to support what the different recommendations are. Here's my funding and disclosure. And in terms of an outline for today, I'll start by giving a brief overview of tobacco use in rural communities across the U.S., talk about the incredible need for tobacco treatment among people with opioid use disorder. And then I'll focus a bit on the topic of my personal research, where I've focused a lot of my effort, which is on providing treatment for people who smoke and who are not ready to make a quit attempt or to try to quit in the near future, which is unfortunately, most people who smoke in the United States, and so directly relates to folks in rural communities and people with opioid use disorder. Then we'll tie it all together with a little bit of information about what's happening here at UVM Center on Rural Addiction with tobacco treatment toolkits. So to start with, as many of you are probably familiar with, tobacco use is most prevalent in rural states across the US. So the data you see on the right there from the National Survey on Drug Use and Health, representative of folks in people in the United States. One fact that people may not be as familiar with is in addition to the fact that smoking is more prevalent, among people who smoke, those who live in rural communities experience more harm from smoking. So smoking associated cancer and mortality is also higher among those who smoke. Rural communities, we also see that cessation is less likely among people who smoke. So the figure on the right is from a really excellent paper. I'll pull up the citation in a second, graphing quit ratios over time. What quit ratios are is the proportion of former smokers over ever smokers, which is not a very person-centered way of saying that, but people who previously smoked over people who ever smoked cigarettes regularly. And so a higher quit ratio is better. It means you're more likely to go on and quit. What you can see there is the problem of a lower likelihood of quitting in the rural population, that gray bar, is pervasive over time in the United States. So over the past decade, we see it significantly lower than people who live in urban communities. That's summed up really nicely in this paper in JAMA Network Open with Andrea Valenti at our center as the senior author. Anyone who's interested, highly recommend this paper. But to summarize that, sort of a triple whammy here. We have higher prevalence of smoking in rural communities, greater harm from smoking in rural communities, lower likelihood of quitting. We need more people like you all on this call providing treatment. So I think that's the important point from those slides. So then moving on to opioid use, how did these substance uses co-occur? There's a similar disparity that we saw in rural communities. People with opioid use disorder experience nearly threefold higher prevalence of smoking than those who don't. So a really high concentration of smoking among people with opioid use disorder or in recovery from opioid use disorder. And again, these are nationally representative data. Similar to the disparity we see in rural communities, this disparity between people with and without opioid use disorder is pervasive in the United States. So, in the past decade, we see this disparity continuing, and significantly so. Again, nationally representative data. So I want to talk a little bit about why some important things to keep in mind with the co-use of tobacco and opioid. So first off, smoking is the second leading cause of death among people with opioid use disorder. And to put that differently, it results in a fourfold higher mortality rate among people with opioid use disorder compared to people with opioid use disorder who don't smoke. So I'll just highlight that again. Among people with opioid use disorder, those who smoke have a fourfold increase in dying. That's huge. And it really drives home something that unfortunately across the US often takes a back seat. Someone comes into treatment for their illicit drug use, and that is the focus, understandably, and tobacco use gets seen as something that either can't be or shouldn't be addressed in the meantime. But what we're seeing here, nationally representative data saying it's actually incredibly important, and one of the best things we can do for patients is to address tobacco use, especially when they're in treatment for another substance. Now, these next two bullet points, I think, are really important because it's counter to common beliefs across the US, which is that tobacco use is associated with an increased likelihood of returning to illicit substance use among people in recovery. And smoking cessation treatment does not undermine treatment for illicit drug use or for opioid use disorder. So there is a fear that encouraging folks who are in recovery from opioid use disorder or in treatment from opioid use disorder to quit smoking may exacerbate opioid use. That's simply not the case when you look at national data across the United States. So all of this is to undermine something that I am sure you all are all very familiar with, which is that tobacco treatment for people with opioid use disorder is critical. Okay, so I want to broaden this just one slide, not the focus of today's talk, to treatment for people with other substance use disorders. And so there's a group called Cochrane who do fantastic, the gold standard of meta-analysis, which means combining data from randomized clinical trials that have ever been done and pooling them together to get one outcome to say, should we be doing this or should we not be doing this? So they did this with tobacco treatment interventions for people who are either in treatment for or in recovery from any other substance use disorder. 35 trials, over 5,500 patients in those trials. The conclusion is that tobacco treatment is effective among people in recovery for illicit or other substance use disorders and does not disrupt the treatment for that other substance use disorder. So consistent with what I just showed you about opioid use disorder, the same message for other substance use disorders, we need to be providing tobacco treatment for folks in treatment for other substance use disorders. Okay, back to opioid use disorder, kind of ping-ponging around here. So a few pieces I want to highlight in terms of what type of treatment should we be providing for people who have opioid use disorder. First, and unfortunately, meta-analyses demonstrate brief counseling alone for smoking cessation is insufficient among people in treatment for opioid use disorder. Really doesn't seem to do any difference, again, on a large scale across the US, any difference than providing no treatment at all. Contingency management. This is the practice of providing financial incentives for behavior change. So in this case, financial incentives for smoking cessation among people in treatment for opioid use disorder is highly effective if you have a large enough magnitude of money, a big enough reward. The major barrier here is often implementation. Unfortunately, treatment systems are often set up in a way that isn't conducive to providing large enough reinforcers to to achieve smoking cessation among people in treatment for opioid use disorder. But stay tuned. Hopefully we can move the needle on this and make contingency management available to more folks. Okay, but pharmacotherapy is also effective among people in treatment for opioid use disorder. These are medications like nicotine replacement therapy, patch, lozenge, gum, and varenicline. Specifically, I'll talk about NRT a lot today, given that that's available over the counter. NRT compared to placebo in meta-analyses showed to increase cessation by 1.5 to over 3.5-fold at a 6-month follow-up among people in treatment for opioid use disorder. So this is important. Okay, but there are some major barriers to treatment, and this is something that I think folks on the call could teach me about quite a bit. If people want to talk about this later, I'd be really curious to hear some things that come up in the literature. Okay, so we know that smokers are people who smoke and have opioid use disorder are far less likely to quit smoking than those who don't have opioid use disorder. Why is that? So what's identified in systematic reviews is high nicotine dependence. And this is demonstrated by the fact that people with opioid use disorder often smoke more cigarettes. And one potential mechanism here is an opioid nicotine drug-drug interaction in the brain that could result in greater smoking, greater nicotine dependence. Co-occurring psychiatric symptoms, people with opioid use disorder have a higher prevalence of other conditions than those without, which can be barriers to treatment. And overall low treatment engagement. And this could stem from readiness to quit or other factors. Today, I'll be talking about some interventions that specifically target treatment engagement by increasing motivation to quit, increasing readiness to go ahead and take that first step and make a quit attempt. But before I do that, I want to do another shout out. Anyone interested in this topic, the treatment of tobacco among people with opioid use disorder, I highly recommend this systematic review. It does a really good job of covering a broad swath of research on this topic. Okay, so readiness to quit smoking. This is a construct that is really responsible for that last barrier, which is just low engagement in treatment. And as clinicians, it's something that you may come up against quite a bit. If you're like me, when I was practicing, I would notice this often. And it's borne out in the data. Nationally representative data demonstrate that the vast majority of people who smoke cigarettes want to quit smoking someday, over 95%. Also, the vast majority don't want to quit smoking within the next 30 days. So what does that look like? People who, when we see them cross-sectionally, so someone comes into my office, I get that hour, I don't often see, them over a long period of time. At that point, in all likelihood, the response would be, I'm not ready to quit right now. And traditionally, that would mean they didn't get treatment. What we see, or the case I'll make is those are the people most in need of treatment, those who come into the office saying, I'm not ready to quit right now. Okay, but before I get to that, to bring this back to the topic of today's presentation, this is even more of an issue in communities that we all live in, rural communities in Vermont, where readiness to quit in the next 6 months is on average lower than those who live in urban communities. And then tying this back to people with opioid use disorder, I haven't been able to find great nationally representative data on readiness to quit among people with opioid use disorder. But in large clinical trials, it appears to be about the same as the general population, which is to say that most are not ready to quit in the near future. A very important thing to understand about readiness to quit is that it is fluid. And I just sort of gave you an example of that, but I want to present some data here, some fine-grained natural history data to demonstrate this point. So these are from a series of natural history studies. And the way to interpret this is each row is an individual participant who smokes cigarettes. Each column is a day. So each pixel is a day. Gray pixels represent a day of reduction. White pixels or white spots represent a day of smoking as usual. Black represents abstinence. And then those days with an I, a little bar, represents a day of intention to quit smoking. So if you're like me and look at this, I can't pick out any pattern. People are all over the place. Smoking as usual, reduction, abstinence, and then intention to quit just sort of smattered across there. And that is the conclusion that this body of work really came to. which is that on any given day, someone comes into your office and they will be very unlikely that they want to quit. But look, they develop that intention sporadically in the days to come. And so as clinicians, we need to be providing folks with the tools to quit so that when inspiration strikes, when they are ready, they can go ahead and make that quit attempt and be successful in smoking cessation. And so that's the theory behind motivation phase interventions. This is similar to work that's been done around stages of change and motivational interviewing. But here we're talking specifically about tailoring treatments to meet the needs of a person who's not currently ready to quit. This was developed largely by a man named Tim Baker at University of Wisconsin. And this often focuses on the very first step, which is initiating a quit attempt, as opposed to traditional treatments, which will focus on maintaining abstinence among people who are already motivated to quit. It's worth noting that there are very few trials that have tested this specifically among people with opioid use disorder who are not ready to quit smoking, and none that have done so among people with opioid use disorder in rural communities. So what I'll be presenting on today are data in the general population of people who smoke cigarettes, with an eye toward how we can apply this to our specific patient populations, people in rural communities with co-occurring substance use disorder.
And Eli, this is great that we're getting to this part to then help move us forward into our conversation as well.
Great, great. So the first thing to take note of here is predictors of quit attempts differ from predictors of quit success. So I think, previously, folks would think of the process of quitting smoking as sort of the same. Turns out that getting over that hump of making that initial quit is kind of a different activity than maintaining abstinence from cigarettes. This was first pointed out by a group in the UK with a meta-analysis of nationally representative data, and then we went out and replicated this among a group of people who were explicitly not interested in quitting at baseline, and again found that predictors differ. So then we went out and conducted a systematic review and meta-analysis to look at all the treatments that specifically focus on taking that first step of making a quit attempt. So they're not treatments designed like to maintain abstinence. They're treatments that say, we want to just get people over that hump of making a quit attempt. I don't care if they maintain abstinence, but that first step. We reviewed almost 2,500 papers and ended up with 25 studies. We had a stringent inclusion criteria looking at only our randomized clinical trials with a longer term follow-up. And one, I think, really interesting finding from this is not necessarily the outcomes in terms of treatment, but how varied this body of literature is. So talk about a need for work. It's on developing interventions that specifically promote quit attempts among people not interested in quitting. So you can see here, there are about 9 different treatment modalities that we identified with only a handful of studies in each. And so we ended up with a series of very small meta-analyses, or very small analyses where we combined trials. Our results have 2 primary conclusions. The first is that the only effective interventions to get people over that hump of making a quit attempt that we found were nicotine replacement therapy and varenicline. So pharmacotherapies for smoking cessation. The second is that we had very low certainty in our pooled effects. So what that says is that future research is likely to change these conclusions. So put simply, right now we're seeing a signal where nicotine replacement therapy is an effective way to get people over that hump and start that quit attempt. Varenicline is an effective way, but stay tuned. Other things might come out of the wood as we continue to do research.
We have about 5 minutes, and then we'll have some Q&A and bring the local conversation in.
Great. So I'll briefly talk about 2 forms of counseling. As I mentioned, there is pharmacotherapy is the most effective, but we can have counseling as an adjunct, which helps. The first is the 5 R's. I won't go into the detail here given limited time, but this is a form of counseling that helps people move toward making their first quit attempt, similar to motivational interviewing. The main difference is that there is direct advice to quit, whereas motivational interviewing tends to roll with resistance, move where people are. Here, we give direct advice to quit. I won't go into these meta-analyses for the sake of time. I'm going to go forward here. The second commonly used counseling is reduction counseling. two forms of counseling. The first focuses on encouraging people to smoke on a schedule, and then increasing time between cigarettes to break up association between cues and smoking. The second focuses on getting rid of the easiest cigarettes and moving on to the hardest cigarettes to increase self-efficacy to quit. One thing I'll say here before moving on is if you're practicing reduction counseling, the goal must be abstinence. So there are a number of studies now that demonstrate that reducing cigarettes per day, unless you're reducing down to zero, does not actually result in much harm reduction at all. So we don't want reduction in cigarettes per day to replace abstinence. And I won't get into our meta-analyses here, although if anyone is interested in following up, I'd be happy to talk about that. So I want to talk a little bit in these last few minutes about what's happening at the Center on Rural Addiction. So providing NRT to people, regardless of whether they're interested in quitting, is known as NRT sampling. This is a model that you're likely all familiar with if you've been to the dentist. When you go to the dentist, you leave with a grab bag full of goodies, whether you are interested in flossing your teeth or not. Well, the same is true for clinicians who provide NRT sampling. If you show up and are identified as someone who smokes cigarettes, you're provided with this tobacco treatment toolkit, and it's up to you whether you want to save it or use it. But the idea is it's there for you to use when you're ready to make that quit attempt. Turns out this is effective. In the general population, studies run by Matt Carpenter and colleagues demonstrate this increases treatment engagement. Again, that crucial step that's missing with so many folks with opioid use disorder who smoke cigarettes, increases quit attempts, and most importantly, increases cessation. So the Center on Rural Addiction provides these tobacco treatment toolkits with, most importantly, nicotine replacement therapy, as well as a number of other resources to help people quit. Just walk you through the NRT best practices, which if you're distributing these is important to know. The first is dual use of NRT is the most effective. So we want people who smoke cigarettes to use both the patch for long-acting NRT and a short-acting NRT, gum or lozenges, to account for breakthrough cravings. Pre-cessation NRT is also the most effective. So especially among people who aren't ready to quit now, we want to encourage them to put on a patch, see what happens. They can be smoking cigarettes and using the patch at the same time. That's completely safe. In fact, increases likelihood of quitting long-term. Same is true if they're a relapse. So if you're smoking cigarettes using a patch and if you're using a patch in abstinence and you end up smoking a cigarette, the instruction needs to be to leave that patch on. Okay, I think I'm still within the limit. I'll just give you a quick rundown of what we talked about today. So if you fell asleep, here are the take-homes. The first is that tobacco treatment for people with opioid use disorder is critical. It's incredibly important, and especially if they're not ready to quit now, because the reality is that's most of the patients that we end up seeing. Pharmacotherapy is effective in these cases. Counseling can be effective as an addition to pharmacotherapy, but really it's the NRT or the varenicline that's going to move the needle in terms of cessation. Tobacco treatment toolkits, or NRT sampling, are an effective way to get that NRT to people who may not be interested in quitting. So this is really the way that we're working on disseminating this effective smoking cessation treatment, especially for people with opioid use disorder in rural communities. So I'll stop there and happy to take questions. Also put this email address here. If you're interested to find out if your clinic or clinic you work with is eligible for these tobacco treatment toolkits, you can send an email to that email address and we'll be happy to follow up. Thanks.
Wow. Thank you so much. This is so valuable, I think, for our local community and especially folks who are on the call today to help, take this to our community. And so there are a couple of questions already. I will, if we get in the chat, and also we can, some of it can be probably responded to in the chat directly, but just looking at the NRT sampling, and you did mention that it is possible to get some from Cora. I don't know if Dana, I know from 802 Quits, like are there does anyone know of other ways that we might access locally free NRT?
Hey, this is Dana. So for 802 Quits, you can access free NRT, but that's kind of like a 2-week window of ordering still. So for folks who are eligible for these Cora Quit kits, I have been working with Eli to kind of promote them very highly. I think anyone who can use these on hand, like that really interesting graphic that I've seen several times from Eli of readiness. If someone is in office and is ready to quit now and you can hand them something today, that's a lot more beneficial than saying, okay, well, let's go online and order something for 2 weeks. That is definitely a barrier of the quit line that we're aware of. So I think connecting with Eli and the Cora team could be a really great
Perfect.
for like on hand.
That's great. And, I also see folks, not just from the recovery center, from LHP to different capacities and schools, health department, and if anyone else has any comments, and the email address, if we can put that in the chat, I think, and also we'll get Eli's slides to be able to send out to all participants. But Eli, if you have a chance to jot that into the chat. There we go, Shannon, she got it so quick.
Oh, thank you.
Are there any other questions? Folks speak up. We'll have a half an hour to really get into conversation, but anything specific related to the presentation? What about similar supports for youth regarding NRT? Does anyone have any information on that?
Sorry, I was muted. That's an area where we are really needing more research. So there have not, gosh, I should look back at the literature. As of about a year ago, we did a systematic review on tobacco treatment for youth and young adults, and there had not been at that time any nicotine replacement therapy trials for youth and young adults. Now, I don't have any reason to think that NRT would not be or pharmacotherapy would not be the most effective treatment in that population. But as of right now, I don't have a great response in terms of research to support that. Dana, do you have thoughts?
Yeah, I was just gonna hop in. So we, as a health department, like 802 quits, we send NRT to basically anyone. We cannot send to folks under 18 because NRT is really just for 18 and older. That being said, we do recommend that if a youth is highly addicted, to talk to the pediatrician. Pediatricians can prescribe NRT for off-label use. So that is recommended from the American Academy of Pediatricians. That's fully supported. So for youth that are highly addicted, there is precedent for using this NRT. They just have to go through a pediatrician or family physician. I know that does get tricky, especially for youth who are trying to keep maybe their vaping addiction from their parents. It gets a little tricky to kind of be like, oh yeah, all you have to do is go to the doctor and show up on your insurance. So we know that again is an issue. I think this is something, and I don't know if Eli knows, but I think nationally this is probably something that pediatricians are trying to kind of have larger discussions on and do some more research. But as many of you know, doing research on youth, especially pharmacotherapy, isn't really going to be the easiest research to do. So I think there is more to come, but I would say for now, recommending anyone talk to a school nurse or their pediatrician is probably the best route to go.
Thanks, Dana. And I wanted to, I see Matt has a hand raised. Matt?
Thank you all. And thank you, Eli. It's awesome. 2 questions and then a further question. Was curious about what you mean by reduction does not equal harm reduction. And specifically, are you saying that there's not much of a difference health-wise for smoking 2 cigarettes versus 20 per day?
Yeah, that's a really good question and something that was surprising statistic for me to learn. That's accurate. The threshold that I've heard, I have to go back, I could send you the paper, but is about 4 or 5 cigarettes per day. So it strangely, if you look at sort of harm from combusted tobacco, the difference between smoking 10 and 20 cigarettes per day is not that great. It's just harmful, and it just stays very harmful. The difference between smoking 5 and 0 is that's where all the change happens. And so because of that, it's very rare for people to reduce down to below 5 cigarettes per day and really stay there. And the worry is that people will say, I can't quit. I don't feel ready to quit, but hey, I just reduced 3 cigarettes. Good for me. I'm done. So reducing cigarettes per day is effective only as a mechanism to increase self-efficacy to quit, to decrease dependence, to get people prepared for abstinence. But yeah, we need complete abstinence from combusted tobacco.
Thank you. That's super helpful and interesting. Can you tell me in all of your meta-analyses, like the effect size of counseling? What is that with the NRT?
Oh, with the NRT.
Uh-huh. Or even on its own, I guess, but you had a slide that said NRT with, I think, some effect from counseling or some sort of term like that. I'm, so I run a mental health agency or a behavioral health outfit, and resources, clinicians, it's limited. And so if I'm thinking about where do I put my resources, if 90% of the effect is the NRT and the counseling is like this little bit on the end, is that the best use of people's time? And so I'm just trying to get a sense of that from your perspective.
I don't have the exact numbers for you. I can get those, but your summary is pretty accurate. Most of the benefit in the general population of people who smoke cigarettes comes from pharmacotherapy. Now, counseling might be useful to get people onto pharmacotherapy, but really that's where we're seeing the biggest effect sizes. Counseling is useful for smoking cessation in the general population alone and does increase the effectiveness of pharmacotherapy. How much that I can get back to you on. But I want to say that with one caveat. Among people with opioid use disorder, counseling alone is not effective.
Mm-hmm. Okay. And then my final question. So I have a staff person who's worked here forever, and she's been doing hypnosis around tobacco cessation for a long time. And she's been very interested, and I asked her to kind of do some of the research on studies that have been done around this, but because she wants to combine pharmacotherapy, hypnosis, and then a group contingency management plan. And she said she found studies with sort of, single variables that didn't, for each of those individually, but combined, she hadn't really, and not that she wouldn't have the resources to find the studies as you do, but just kind of curious, like from your knowledge base, to put the time and energy again into creating a model that's sort of that comprehensive, if you will, and labor intensive and time intensive for the patient to stick to it. Do you see synergy there and possibility for more effective treatment, or is it just kind of a waste of time to throw all that at it?
Contingency management, there is lots of evidence that it is very effective if you can provide large enough magnitude of reward. Nicotine replacement therapy, I think that was the second piece you mentioned. Lots of evidence that that's very effective, especially co-use of long-acting and short-acting patch and either gum or lozenge. Hypnosis, there is not supported in the literature, and as far as my understanding of it. And I think there are individual studies, smaller studies that have found effects, but in the last review that I saw that looked at a series of less commonly used treatments, when you pool across effects, there wasn't evidence to support helpfulness or harm from hypnosis. So that always comes with a caveat that if that gets people in the door and gets them using NRT, great. But hypnosis alone, I don't think there's evidence to support that.
I'm so glad that there are so many questions, and I want to, I see Dana has a question. Jane, I wonder if you can put in the chat, and we'll get to it in a couple of minutes. I want to just bring us together and have us reflect on what we've learned and what we're thinking about so far. And I'm going to open a whiteboard. Not sure if you have ever seen this, but it's a way to collaborate. And you can just click on it, you'll see, and you can actually make it larger and kind of move over your chat. Jessica's going to show us how, but I put in the chat, if you can, write down in your own, little box where you go, and then you can click on, to put some text in here. And you'll have your own space. 3 considerations that you're already thinking about for applications and advancing this work and what we've heard from Eli and what we're hearing from other partners locally. Just 3 things you're thinking about just to jot down quickly. We'll just spend a couple minutes so that we can capture that, at least for today, knowing that, you know, this is really just launching this. I think also if you're not seeing text come up on the whiteboard, if you can put those things just directly in the chat as well. I'm not sure. I'm not seeing what anyone else is writing. I'm not sure if any of you are. And Jessica, feel free to jump in if you see something that I don't. Great. Thank you for putting it in the chat. Folks are starting to do that as well.
Yeah, and if you click on the text button, and then take that over to the whiteboard, that's a great way to do that on your own. You can create your own text box. So there's a toolbar on the left side of things. That's where I found that ability to create a text box.
Great. I'm trying to show folks now where the text is, if you can see mine, and then just trying to pull it over. And if not, if you can just, you know, put a few things in the chat, that would be great. And Val, you're next up. So I'm glad we're capturing. Please continue to write any other, you know, as we're moving on, any other questions, comments, and just ways of connecting locally in the chat as we hear some more local conditions. So I'm about to close the whiteboard, so that will gather and we can get back in the notes out to everybody, and you know, we can continue in the chat. So Val, I've asked Val, and in collaboration, just figuring out what kind of data. I know Wendy contributed to this. I know Shannon has some information of what nurses in particular at LHP have been doing. So I'd love to hear more about what's happening locally. We don't have a huge amount of time, but just to help launch us. So Val, do you want to show us a few of those slides now? And
yeah, you need to, right now the screen sharing is disabled, so.
Okay. Well, I think now you're set.
Okay. Are you seeing? Okay. I think you got it. All right. So I'm going to go through these really quickly. And this is high level data, and you will be getting these slides and others after this presentation. So, and the data that I'm sharing, most of it comes from the health department, which is a collection of the adult risk behavior survey, the youth risk behavior survey, 802 quits, maternal child health annual report, and Medicaid claim data. And yeah, it's just a broad brush today. So, so this slide tells me that there has been little change in smoking rates among adults However, adults with disabilities are more likely to smoke than adults without. Other trends follow national data regarding lower income and higher high school or less education, resulting in higher smoking rates. And as you can see, Chittenden County is statistically less than the state average regarding smoking rates.
Now, we haven't seen any slides progress. If they're
Oh,
supposed to.
really? Because it's showing on mine. I'm sorry. Okay. Oh, is that working?
No, we're on the title still.
Yeah,
Oh, for heaven's sake. So, oh, darn
you
it.
might need to put it in slide present mode.
Can you, what are you seeing? Oh, shoot.
Let me see if I can
This is
share.
not, I'm not wasting time. I'm sorry. Oy.
Val, keep going and I'll try to see if I can share it from my end. Why don't you stop your share?
Okay. All right. So sorry about that, folks. Basically, so I'll do my best in describing things here. So in terms of the breakdown of counties regarding smokeless tobacco, Caledonia towns are more likely to use smokeless tobacco. And with the tobacco program that we're seeing that quit attempts among high school students statewide is increasing, but overall there has been a steady decline in cigarette smoking. No statistically significant change in adult smoking rates since 2018. Other data, which is not in this slide deck, show that there are no statistically significant differences between Vermont and US regarding smoking rates and trend. Are you folks seeing this slide now? Interesting.
Val, I think you would need to share one more time to see if it works.
All right. There's different slides I can, okay, interesting. Are you seeing it? What are you seeing now?
The local data slide. Local data for Vermont.
It is moving, Val. It is
Okay.
moving. Yeah.
All right, let's get to where I am now. Quit attempts. Okay, so over half of Vermont adult smokers have attempted to quit smoking, and there is no statistical difference in quit attempts among various population types. So meaning education, BIPOC, disabilities. Here we see, this is a most recent report from the 802 quits. And 802 quits data, which phone enrollments are steady in Lamoille County with an average of 5 new enrollees each month, which is on par with other counties of similar size. And here's a quick screenshot of Morrisville district data, which includes all of Lamoille County, so Lamoille North and Lamoille South supervisory unions, plus the towns in the Orleans South Supervisory Union, which is Hardwick, Standard, Woodbury, Crosby, and Greensboro. And here at first glance, I noticed that marijuana use has increased while cigarette use has decreased. And here, I think an interesting point that's noteworthy is 9 out of 10 adult smokers started before the age of 21. And 70%, so 7 out of 10 started before the age of 18. And here we see that of high school youth, that in Lamoille and the Morrisville district and the hospital service area, we have a rate of 10% of students, high school students, and which is statistically worse than the state average. And for adults, it's the same as the state average. Here, I thought this was the point I wanted to make here in related to Eli's presentation in terms of harm reduction, risk reduction, trying to move the needle from the number of cigarettes smoked per day So in this case, we just learned that 0 to 5 should be our target, but moving from 10 to 20 down to less than 10, there's some potential ability there, and then obviously reducing the onset of smoking for youth. Here, this emphasizes that adults with disabilities smoke at 3 times the rate of those without disabilities, any disabilities, and the rate of current smoking increased among those with multiple disabilities. And here, Lamoille and Caledonia are statistically similar to Vermont, and Orleans has higher rates of electronic vapor products. Here we do see a statistical significance of higher rates among BIPOC youth who initiate smoking before the age of 13. And the point on this slide is that not going into a lot of depth about the youth risk behavior survey, because each school gets their own data, and Healthy Lamoille Valley is available to support schools in interpreting their own data and using and getting to why as one strategy they can use to improve outcomes. But here I wanted to note that and this is the Lamoille Middle School results that responded that their parents or guardians feel it would be wrong or very wrong for the student to use marijuana, and Lamoille was statistically less in thinking that was true than the Vermont average. And here, regarding maternal child health data, that Vermont typically exceeds the Healthy People 2020 targets for related maternal child health objectives, except in smoking. And so the circle, that's the Morrisville district. And the color codes are 2017 through 2020, going towards the left. So it looks like 2020 smoking rates in pregnancy were less in 2019 and 2020. And then here are quit smoking attempts in pregnancy. So we had a big bump in attempts in 2019. But it's gone back down to the usual for 2020. And then we're coming to the very end here, and I have to make a note on oral health. While I don't have data here, but in their plan of action, increasing tobacco screening and referral process for youth into pediatric and family dental practices. So, and just doing screening in the dental office. So here are resources that you will get after this presentation. And that's it for me.
Thank you so much, Val, for highlighting, locally, and Dana for supporting that information, Wendy and us all working together behind the scenes. And I wanted Shannon Chauvin to also share just, what you're doing at LHP. I think it's relevant, and it's one of the systems maybe this group continues on with to address. Shannon, would you share a little bit about the data you guys are collecting and what you're thinking about this? You just need to unmute.
Let's try that again. Thank you. Hi, everyone. I'm Shannon Chauvin, Director of Quality here at Lamoille Health Partners. So Lamoille Health Partners is a federally qualified health center. And as a federally qualified health center, we are required to report on specific clinical quality measures to ensure that we're providing quality care to our patients. One of the measures that we are required to report on is tobacco screening and tobacco cessation intervention. And this year, we made a little change here at Lamoille Health Partners, and we initiated the tobacco screening and cessation intervention into the nursing staff's clinical ladder. So we currently are auditing the nursing staff to determine, did they do the screening? And if the patient screened as a tobacco user, did a tobacco cessation intervention take place? We follow the CMS guidelines, and the interventions that do count here are whether or not you prescribe prescription medication, you refer the patient for tobacco cessation counseling, you provide the tobacco cessation counseling on site, or you offer the patient NRT. And we started out the year at a compliance rating of 78%. And as of December 1st, we are currently at 93%. So we have, we have moved our compliance rate quite high compared to, where we were at the beginning of the year. And we have lots of feedback from our nurses. We provide them with real-time feedback of, for example, we're doing the audit. We say, you did miss the screening on that individual. Could you share a little bit more information of why? And really, it tends to be emergent visits where that's where the screening is not taking place commonly. I tried to really summarize that quickly.
Yeah,
Does anyone have
that's
any
great.
questions?
I know we're approaching time, and 12 to 1 is tough to get so much in. And I want to mention that we're hoping to continue this conversation. This is really just a launch, and to get us thinking as a community, and for us to then maybe, if you are interested in continuing the conversation as part of within our community of what we can be doing for another couple of sessions, email me or write in the chat so that we can see what we can do together as HLV works on this systems level. But I know, I'm happy to stay on. I know I want to thank Dr. Klemperer. I want to thank Val, everyone, Shannon and Ken for really helping to bring these ideas and bring this to our community. And I am really happy to, and Dana, thank you for all that you offered. I think, so much knowledge, so many experts on this call. Shirley, I feel so honored that so many people have been here, but I'm happy to stay on for just 10 more minutes and close it at that if folks want it, for anyone who does want to stay on for another 10 minutes. But otherwise, appreciate everyone being here.